Maintaining a healthy gut is key for overall physical and mental well-being. Whether you're a health-conscious advocate, an individual navigating the complexities of living with GI issues, or a healthcare provider, you are in the right place. The Gut Health Podcast will empower you with the fascinating scientific connection between your brain, food, and the gut. Come join us. We welcome you. Hello, friends, and welcome to the Gut Health Podcast. We are your hosts. I'm Kate Scarlatta, GI dietitian.
And I'm Dr. Megan Reel, a GI health psychologist. In today's episode, we are diving into the science and growing awareness surrounding mast cell activation syndrome. This is also known as MCAS. This complex immune condition happens when mast cells release excessive inflammatory chemicals like histamine, tryptase, and more, triggering symptoms that can affect nearly every system in the body. It is complicated.
It is complicated. So from chronic hives and digestive issues to brain fog, anxiety, fatigue, and even rapid heart rate, MCAS, or mast cell activation, is often misunderstood because its symptoms can mimic allergies and other chronic illnesses. Researchers are also exploring links between MCAS, long COVID, dysautonomia, and connective tissue disorders, making it an increasingly important topic in modern medicine. In this episode, we'll break down what mast cells actually do, why inflammation can spiral out of control, and how patients are navigating a diagnosis and treatment in a condition that still leaves many unanswered questions.
So whether you're personally affected, caring for someone with MCAS, scouring the internet for information, or simply curious about the emerging science in this health topic, this conversation will offer insight into one of the most talked about immune disorders today. We've also got a fantastic expert guest, gastroenterologist Dr. Zac Spiritos, who treats a wide range of gastrointestinal and liver disorders with specialty interests in irritable bowel syndrome, functional abdominal pain, motility disorders, and dysautonomia. His practice also sees many patients with postural orthostatic tachycardia syndrome, or POTS, and mast cell activation syndrome. He is also well-versed in gastrointestinal complications associated with hypermobility syndromes like Ehlers-Danlos syndrome, or EDS. Dr. Spiritos is passionate about patient education and a holistic approach to GI health. He integrates nutrition, lifestyle modifications, and gut-brain therapies into his practice, and we will certainly dive into this in our episode. Outside of medicine, he and his wife stay very busy with their 2 young children, and they enjoy being outside, playing basketball, and exercising whenever he gets a chance.
Welcome, Dr. Spiritos. We are so glad you're here. And we always start our podcast with a little myth busting. So can you share a myth you'd like to bust about mast cell activation syndrome, or MCAS?
It's really common. It's not a rare thing.
Yeah, I know. Mainstream is starting to catch up, right?
Yeah, I mean, I think there's a lot of idiopathic conditions out there that we're taught just happen primarily to women, that we just say, you know what, you're going to have to see a pain doctor for this and a therapist to deal with the pain and maybe take a neuromodulator. But beyond that, we're not really going to figure out much more than this. You know, fibromyalgia, interstitial cystitis, complex regional pain syndrome, vestibular migraines, IBS, right? And so there's these conditions that when you look at the data, like there's inflammation here, albeit it's not overt. Like these aren't whopping ulcers on endoscopy. It may be just, more white blood cells on a urinalysis, but there's no bacteria, right? But people have signs and symptoms of a UTI. So just because we may not be elegant enough yet to detect these things, it doesn't mean it's not real. And if you go back decades, like there's suggestions that inflammation really exists around some of these quote unquote idiopathic conditions. And when you take that next step, you realize that, man, there's a lot of mast cells in a lot of these conditions. I think that's where we need to just we need better conversation and more data around why this happens and how to go about fixing it.
Yeah, and helping a lot of people that are suffering and jumping doctor to doctor. It's tough out there. So how would you describe mast cell activation syndrome to a patient? And you kind of talked about why it's controversial a little bit, so we don't need to dive so much into that, but why don't other doctors really know about it? So this is kind of a two-part. How do you explain it? And why don't you think some doctors really are just not nailing it?
Yeah, I mean, I'll go into the why we don't recognize it. It's because we weren't taught about it, right? Like we go into IBS, like as in a GI fellowship, we learn about peptic ulcer disease and Crohn's disease and cancer. There's nothing on IBS, but it's the most complex condition out there, right? I define it as a neuroimmunologic condition. And, that's a bigger conversation. And why don't we know a lot about it? It's because it's probably controversial, but it mainly affects women, right? I think this is a white guy disease. We would have figured this out decades ago. Mm-hmm. And maybe that's a controversial take, but ever since, going back 100 years, right? Women's issues were blamed on hysteria, the wandering uterus, right? Like there's roots in history that are very disturbing that, albeit we are more aware and woke today, but I mean, there's so many women who go to the ED get less pain medications than men, right? Like we see this time and time again. And oftentimes in mast cell activation syndrome, and we can get into the why, people have symptoms beyond their GI tract or beyond one symptom, right? And so we're siloed in medicine. So when you go to GI clinic and you have IBS, they're not trying to hear about the brain fog and the fatigue and the vestibular migraines and the palpitations that don't make sense, right? It's under the guise of, oh, you must be anxious, right? Because this is what anxious people get, right? And I had a panic disorder for like 10 years through medical training. I didn't have a single GI symptom, none of this, right? So it's not anxiety. It is a real set of symptoms that has inflammation behind it. Anxiety certainly makes it worse, but I think it's easy when someone comes in with symptoms across multiple organ groups to say, oh, they must be anxious. And they also are intolerant of a lot of medications. And I was taught, or the culture was, oh boy, this patient's coming in with 11 allergies to medication. They're probably not easy to deal with. It's like, no, they want to tolerate medication, so they just can't, right? And so this construct of what this person is, and it must be supraintutorial, must be all upstairs, right? But it's not. It's not. Yeah. It's inflammatory. And I have hundreds and hundreds of patients that back this. And so I think that's why it's dismissed. And we're not taught to think across multiple organ systems. Like GI doctors look at the lumen, right? We're lumen doctors. But it turns out that most people that walk in a GI clinic with symptoms, you're not finding the reason within the lumen, right? So what is it? What else is there? Well, it's the nervous system and the immunologic system, right? And so I spend most of my day trying to understand what happens in the lining of the GI tract with all the immune cells here and how they communicate with the nervous system, because these are all neuroimmune conditions.
So many of our patients are getting siloed, and I think it's not necessarily by the choice of the physician. I think that's how our system is set up these days, where you are the gastroenterologist, you are the cardiologist, you are the endocrine specialist, you are the psychologist. And MCAS really is one of those diagnoses or conditions where having time really makes a big difference because it is so complex. And that is a luxury that a lot of physicians just don't have these days, which then the patients suffer.
Yeah. I was taught that the patient gets two things they can talk about, right? Because there's just not enough time in 30 minutes to get through this. But, truth be told, they do have a whole log of symptoms because they do. And it's not okay to say you have two because it's minimizing them to two symptoms within the specialty that you're treating them. But to your point, that's how we were taught. So I put no blame on any particular physician if they're, having a difficult time managing these folks. And it can come off as dismissive when you're just like, I just don't have enough time for this. But I think providers are set up to fail and patients are set up to not be adequately taken care of in the current system that exists, which is really tough.
So when somebody gets to you, how do you deliver that diagnosis of MCAS? Like, what's your pitch to them? I know, I have one, and we think about gastroenterology, the pitch for how to understand IBS, the pitch for starting to understand the complexities of a chronic disease. what is your pitch for helping a patient begin to understand MCAS?
Yeah. So I do think it's very much an environmentally triggered condition. I've never seen people feel so poorly in one environment and feel so great in another one. I tell people that the mast cells they're just doing their job. They get all the blame, but they're just doing their freaking job. Mast cells are sentinels in the body. They are positioned at every environmental barrier within our body. So sinuses, respiratory tract, GI tract, bladder, and what evolutionarily, they're meant to look out for threats. So viruses, bacteria, parasites, and also wound healing. But in mast cell activation syndrome, they're reacting too much because they're getting too many signals. And I do think that it's an issue with barrier dysfunction, that we have these epithelial barriers in our body, in the nasal passages, in the lungs, in the GI tract. And when those get compromised, the immune system just sees more. And I don't think it's any surprise that since the Industrial Revolution in the 1960s, there's been an explosion of atopic conditions and autoimmune conditions. The immune system is freaking out, right?
Mm-hmm.
There's a growing body of data and I'm no environmental scientist, but processed foods, polysorbate from ice cream, exhaust, pesticides, like they can mess with some of these epithelial barriers. And for some people, it's irreparable, right? And some people, when they move to different countries, they feel so much better than they do here with MCAS. And so I don't think it's a mast cell problem. I think it's a barrier function problem. And that's kind of how I phrase it. And that's how I talk about it. And a lot of folks also have hypermobility. So they have a lot of loose joints, but they also very overcompensating musculature. So hypermobile Ehlers-Danlos is virtually overlapping with MCAS almost 100%. In my personal experience, albeit we're kind of still understanding all of this. And so they wonder why they have really tight cervical muscles, or they have pelvic floor dysfunction when they're 25, female or male, because not only do they have loose joints, but they have muscles that are trying to overcompensate for the laxity of connective tissue elsewhere. So the muscles are really tense up here because it's trying to hold the head up, and the pelvic floor is really tight. So people often describe they can't get everything out. So I try to at first describe what MCAS is, in my opinion, but I may not be right. I think we're all figuring this out. So I use the data that I have at my disposal, but recognizing that in 6 months, I may be telling a whole different narrative. So I take what I say with a ginormous grain of salt. Yeah. And then I try to explain why they feel this way in their bodies and how it's all connected and why they get small fiber neuropathy and POTS and how this all plays together. And then I dive into the therapy plan, which is environment and diet and sometimes medications as well. Because once you create the construct that this is the mast cell just doing its job in the world that we live in, it sets the stage for the therapies that we talk about.
And stress too.
Stress, right. And so corticotropin releasing hormone, there's a receptor for mast cells for CRH. So, when we talk about GI psychology, I've always wondered why does it work in IBS? Sim for low FODMAP, right? And so why we always got low FODMAP by way of mast cells create increased intestinal permeability, right? Why does GI psychology, why is it so important in IBS? And I really think it's CRH on mast cells. I really think that connection is real and dialing us down from sympathetic to parasympathetic tone. And I've treated people's MCAS just by using therapy and guanfacine, and the reactivity calms down a lot. And so it's all connected, and it's just trying to figure out what kind of angle to take. But yes, the stress is so important.
In that diagnosis that takes forever to get, and you're bouncing around, that's not stress provoking.
It lights up. I just think about the poor nervous system is just lit up like the New York skyline. It's just lit up. And so anything we can do to kind of dampen some of that activation. And that is why for some patients, they may benefit from our brain gut behavioral therapies, but oftentimes not just that. So as you said, there's so much that we're learning. And that's why we appreciated you coming on, because you are somebody that is, overturning some of these puzzle pieces and individualizing care based on the science that we currently have, which is so ever evolving. So let's talk about another mast cell mediator, histamine. I think if you Google MCAS and histamine is going to come up here. It's been hiding in plain sight as a driver of complex multi-system illness. And so if you believe this, why has mainstream medicine been so slow to catch up with all of this?
There's data, right? If you look back, there's data on cyproheptadine in IBS, right? There's data on what's another antihistamine that's been studied? Ketotifen is a mast cell stabler, but as an antihistamine, like there's been kind of groundwork here. So to put histamine in context of mast cells, like mast cells secrete over 1,300 chemical mediators, and histamine is a pain, like an absolute pain. And there's receptors all over the place, like the brain, the cardiovascular system, obviously the GI tract, the nerves. Like I've seen people's like nerve pain get better with frickin' Pepsid.
Mm-hmm.
And so antihistamine is always a nice place to start, but there's also like 1,300 chemical mediators that mast cells secrete, like prostaglandins and leukotrienes and interleukins, right? Like tons of inflammatory signaling. So antihistamines can be helpful, but it's, some people are like, I didn't respond well to antihistamines. Could I still have MCAS? I was like, 100% you could, right?
Yeah.
If you could treat this with medications, you could pick up an IL-2 from CVS, like this would be a piece of cake, but it's not. But the question is, why are we late to this? I don't know. I mean, I think it goes back to like there's symptoms all over the body, right? Which doesn't really fit a paradigm that we have outside of maybe like lupus, right? Or TB, where it's like it can do everything. We don't have great diagnostic data points. Like I used to order like $2,000 worth of lab work on everybody, and it'd be like, this isn't good. And I still think you have MCAS. And they'd be like, well, then why do you make me go through all those jumping hoops and like urine tests and blood tests? Like, that's just what we do. We order tests. And I was like, we don't have yet a construct to work up these patients. So I don't even do it anymore. So we don't have good data points. It affects people that have historically been overlooked and dismissed. And it affects various parts of the body and can easily be dismissed as being anxiety related. So it's like the perfect storm of, gaslighting is like implies intent, but certainly like it's being overlooked and not yet fully recognized by everybody.
I think of it like SIBO and MCAS. It's like, you see it now. There are people that are adamant that small intestinal bacterial overgrowth does not exist in IBS. And then you see people get treated and feel 100% better, and clearly there's something there, right? And I feel like MCAS is in that same camp. We just got back from Digestive Disease Week, and it's still quite controversial, and some people are fully on board or partially on board. We're starting to see signals like out of Bill Che's lab with Prashant Singh and FODMAP and mast cell activation and intestinal permeability. So things are popping, but there's definitely camps. It seems like almost like it's controversial, which is unfortunate, I think, for patients, because some patients are getting, some level of gatekeeping. Like, I don't believe in that diagnosis. And it's like...
Top diagnosis. Then I was like, tell me this then. What else is going on? And you can't use the word anxiety.
Right.
An alternative diagnosis. Anything. Just go for it. What is episodic, multi-system condition that in someone who has hypermobility, just give me one thing that does this? And the answer is there's nothing. Right. Jay Pasricha up at Mayo.
Yeah, love him.
I've never met him. I'd love to meet him one day. He published a paper at, I think it was New England Journal of Medicine about functional dyspepsia. He's like, look, there are eosinophils and there are mast cells here. And like the eosinophil mast cell connection is just fascinating. So a lot of people with MCAS also have eosinophilic esophagitis, eosinophilic gastritis. Like mast cells, when they start freaking out, they're like, their best buddy is the eosinophils. Like, get on over here. Eosinophilic disease. And then you realize that this all makes sense. Like immunology is an immunologist's job. GI is a GI doctor's job.
Yeah.
This is both. And so until we can get merging of the minds, it's going to continue to be left siloed.
Nick Talley's another one too. He's written a lot about it, and he talks a lot about the role of mast cells and eosinophils in a variety of, quote unquote, functional bowel disorders. So he's definitely getting the word out. I think people are starting to sink their teeth into it a little bit, but then connecting it to mast cell activation is like another extra leg. Yeah. There was a really good paper, and we'll share it too, that looked at certain IBS medications that also had antihistamine effects, like tricyclic antidepressants and ebastine and other drugs that are working in IBS, but they actually have antihistamine effects. So that's another connection. And that was a really good paper done by, I think, Alex Ford and Heidi Stodacre and colleagues. So that's an awesome paper, and I'll post that one too.
I studied under the great Doug Drossman, and he's a lot of neuromodulators. And I was always wondering, why did these work?
Right.
And it's tough to have the dialogue with a patient because they're like, you're using an antidepressant. I may be stressed about my symptoms, but I am not depressed. And then that was one of my first inroads to mast cells. Like, what do these medications do? I was like, they have pretty significant antihistaminergic properties. And it's like, well, maybe, I don't think it's all it does, but yeah, that's a lot of these mirtazapine, similar thing, Seroquel. Yeah.
Yeah. There's been some really interesting viral trends going on TikTok and Instagram looking at, combining antihistamines, H1, H2 blockers, and getting some attention in various disorders. So, like so many therapies in IBS, I see many of these are grassroots efforts, patients sharing with patients. Not always the best way to get educated in some ways, right? We want to see some research, and there really seems to be a failure here in formal research in this area. Would you agree with that?
Oh, 100%.
Yeah.
I think it starts with we don't have diagnostic data points. I think there's a couple different camps of how you even diagnose MCAS. So how do you run a study with something that it's controversial that it even exists, let alone we don't have diagnostic data points. So how do you even pick your consortium? How do you pick your cohort? And it's so hard to do. And anytime you try to publish it, you're going to run into issues. Like, how do you know they even have MCAS, right? Like, it becomes really, really fraught with issues when you lay out the logistics of trying to run a research study.
True, but we don't have a biomarker for IBS, and somehow they seem to get around that as well. And, so are they all IBS patients? Who knows? And, you got to start somewhere. So we can't just be waiting for a biomarker, right?
100%. I'm fully on board with running, collecting my own data right now on various therapies, because the goal is to phenotype these patients.
Yeah.
Which is really hard. And I've started to kind of get a sense of like where people live. And I've identified like 5 different phenotypes, but it's all based on gestalt and gut feel, which is I'm just a guy in a room thinking about this all day, which is like inherently fallible. It'd be nice to be able to kind of be like, all right, well, if someone presents with X type of, their symptom cluster is this, then they will respond more to X, Y, Z.
But that is the way some of this research works, right? Is that you're collecting enough people coming to a place where you're starting to obviously use the science, but humans are N of ones no matter what. And especially we're learning that with this. And so kudos to you for collecting the data and coming up with some standardization of how you're doing that to help start to get this path a little bit more run down, as opposed to like path over here, path over there, path over here. It's important. I did that with our GI behavioral health program many, many years ago. I'm like, I am seeing a lot of these patients. Let me collect data. Some of the work that we're doing is, again, just kind of personalization and observation too, because we get so many different comorbidities of patients. I'm not just seeing a patient for IBS very often. I'm seeing patients with a lot of different things happening for them and trying to find the treatment plan that works best. So it's, I think, going to be very exciting to see what you and other people that become really interested in this and help people. We have to move the field honestly forward, and that's going to happen. And this is the baby. MCAS is kind of in its infancy in terms of where we're at with this diagnosis and treatment.
What complicates things even more is that these folks are disproportionately affected by GI conditions that I was taught I'd never see in my entire career. So by definition, if people have hypermobility, they're at higher risk for median arcuate ligament syndrome, superior mesenteric syndrome, May-Thurner disease, which is only thought to happen in postpartum women, but you see it in 18-year-old guys. And there's no data or even a pattern recognition that we're taught of like how these conditions look, and they overlap tremendously. So like I'm realizing that everything that I was taught was rare. They just happen to people with hypermobility. And so it's like my first thing to look at is, are you hypermobile or not? Because it completely changes the menu of things that you're looking at. Like when someone has nausea, you got to think something different. If someone has pain, like it's probably not H. pylori. We look for H. pylori, but it's probably something different. And so that's, I think, what I'm trying to actually put out there as well, is that we should really be better at identifying hypermobility, because it just changes the entire narrative and it colors all their symptoms differently.
Yeah, we're definitely seeing some awareness on that. We had Brennan Spiegel on and he was talking about just shaking a patient's hand and like click, click, click and asking about hypermobility. And I'm definitely doing that more. It's like, were you a gymnast or dancer? Like, you super flexible? Like, yeah, why? I'm like, let's get you worked up and, see what's going on.
Pull the thumb back. Pull the thumb back.
Exactly.
Yeah.
Exactly.
Yes.
Most sensitive question is tight cervical musculature and tight pelvic floor.
Mm-hmm.
Well, that's like every woman with IBS. But I'm like, is it stress because you're so tight? But yeah.
I don't know. Does stress, again, I bring it back to like, I was stressed for so long and I never had any of these symptoms. Does stress cause that? I don't know if stress causes unless you're just like, maybe you're walking around like this all day, but like, they really feel like it's so tight here. Their head is too heavy for their head. Ask those questions. Like that's the most sensitive screening that I've found yet, as opposed to the bite and score. And the EDS Society, Laura Bloom are doing amazing things. Chip Norris down in Charleston are doing amazing things to rewrite the definition of like how we approach HEDS. But that's, I don't think I've seen anybody without hypermobility in like a year in my clinic. And so those are the questions that I find to be the most sensitive.
Yeah. It's a big overlap.
What if the secret to feeling happier and healthier lies in your gut? It's true. Your gut produces about 90% of your body's serotonin, the feel-good hormone. That means what you eat and how you manage stress directly impact not just your digestive health, but your mood too. For the 11% of people globally living with irritable bowel syndrome, this connection is life-changing. IBS can feel overwhelming, but there's hope. Introducing Mind Your Gut, the science-based whole-body guide to living well with IBS. Co-authored by GI experts Kate Scarlatta, a GI registered dietitian, and Dr. Megan Reel, a GI psychologist. This guide offers a holistic and evidence-based approach to reclaiming your life. With targeted mind-gut techniques, practical nutrition advice, and gut-soothing recipes, it's your complete toolbox for managing IBS and feeling your best. Don't let IBS control your life. Take charge of your gut health today with Mind Your Gut. Available now in hardcover and audiobook formats wherever books are sold. Well, another overlap, we've mentioned this earlier, is IBS. And as we said, it's certainly a diagnosis without an organic biomarker. How much do you think could be rooted in immune dysfunction or mast cell activity when we think about IBS?
That's a good question. I have my issues with the term IBS. I really do.
Me too.
Yeah, it's just such a bad name, guys.
Yeah.
But mainly because, people usually fall into the IBS bucket when their endoscopies are normal, right? And so without a proper look for SIBO or exocrine pancreas insufficiency or fat malabsorption or small bowel Crohn's or alpha-gal, whatever, right? But if someone has done their due diligence and ruled out those things, and I would also argue a lot of people with MCAS have SIBO but don't respond to SIBO therapy, and that's a different conversation, that a lot. Like if you step back in clinic and you say, hey, do you have symptoms outside of your GI tract? Like how much time you got, right?
Yeah.
Mm-hmm.
There are people that exclusively have GI symptoms, but like, the post-infectious IBS crew, like why do we think that happens, right? It's mast cell-driven intestinal permeability. Like it's what happens with a lot of these folks where they're living their lives. Maybe they have some background symptoms and then boom, something happens.
Right.
COVID, vaccine, pregnancy, something that is very immunologic, and then nothing's ever the same, right?
Mm-hmm.
And so I think a lot, assuming the diagnosis is true. There's so many papers on mast cells in IBS folks. Like there's not only in quantity, but where they're located close to the nerves, how much they degrade. Like the studies have been done. There's like 6 of them, but they're out there, right?
Yeah.
But I think all of them, I don't know. I don't know. You guys think?
Yeah. It's funny. You don't know until you know, right? So once you kind of get it and you're connecting the dots, I can remember it was like, I don't even know how many years ago, a while ago, about 10 years ago, I started noticing like certain patients had a lot of facial swelling or hives showing me things. And I'm like, there's something here. This is a different kind of patient than, someone just coming in. And I hate to use the word just because bloating and pain, abdominal pain can be terrible to live with, but not really having these other additional symptoms, or patients that maybe didn't benefit from some dietary intervention, need a little bit more, still looking. And just once you see it, you see it. And it does make you like, And fortunately, we do have a mast cell clinic in Boston, but it's very, very difficult to get in, and even more difficult now because the word is starting to get out and they just can't handle the number of patients. And that's a whole other conversation. It's hard to find someone. I send them often to allergists, immunologists, and it's like, oh, we don't believe in mast cell activation syndrome. Okay, thanks.
Another thing that's really hard is that a lot of patients complain of brain fog and fatigue, and doctors have no construct for what that means.
Right.
And so when you do this for a while, I know exactly what to do with brain fog. I know exactly what to do with fatigue. But it's like, well, are they iron deficient? And outside of that, I'm not sure what it says, right? It must be stress. How's your sleep? And so obviously sleep's really important, but they complain of certain things that we just don't even know what to deal with. They bloat tremendously. The bloating in MCAS is like out of this world. I'm going to say something else controversial. Anybody in the BBGI world, I'd love to have this conversation. Abdominophrenic dyssynergia gets better with mast cell therapies. I have dozens of patients who I put on a therapy that I'm not even going to say because it's even going to cause more controversy, pre and post pictures. It gets better with mast cell therapy. And I'm sure there's an APD subtype that gets better, that is truly like a coordination issue. But if you look more broadly, all these patients have MCAS. And this is the first time I'm saying it out loud because I realize I feel like I'm going to step on some toes here. But hey, it's my experience. And I will...
die on that hill?
It's patient attestations because I'm going to write it up because I have patients with like their pre-pictures where they show me pictures of their abdomen that as soon as they eat, it's not bloating. I mean, what APD is, but it's a swelling, right? You look more broadly, they have tons of other symptoms, but they eat and they just like whoosh. And I've never seen anything like it. And I used to think APD and, I send them through diaphragmatic breathing. And I wonder if diaphragmatic breathing, because it kind of, mast cells can get worse.
Benefit, yeah.
Yeah. And so it helps people kind of engage that parasympathetic tone. And that's the way you get at it. But goodness, I've seen people turn around with mast cell therapies. But yeah, I'm not dying on I don't.
You're not going to die on a hill?
I think there's something inflammatory and immunologic here that we have yet to really put our finger on.
Yeah.
And that's the thing, right? It is exciting and it gives people another potential option besides the breathing, that they have to find a provider that has trained in Barcelona, who knows the new protocol, or is a GI psychologist that has, it's not a straight pathway for so many people. So if you can write that up and you can show your data, I think the world will welcome that because we just need more treatment options. Period.
Exactly.
There's a lot of
that are evidence-based.
I think I'm a little bit nuts, right? Because they're like, you did what to this person? And I get it because everything is off label. And the therapies that we're sometimes using are crazy, but it's all about matching pathophysiology with how medications work, right? And so low-dose GLP is a perfect example, right? At face value, it's like, what are you doing? But if you understand, or if you think about how we believe mast cell activation happens and how GLPs work, it's like, it kind of makes a lot of sense. GLPs are one of the things our intestines do to patch up tight junctions, right? And there's data for that. And there's a reason why they're looking into it to treat Crohn's disease in UC, and why people with IBD tend to do better on a GLP than not on a GLP, right? It gets wacky, but in a world where we don't have good solutions because there's been no studies on this, right? And you have to reach into a bag of tricks that is very unconventional.
And is it fair to say, I think it's important for our listeners to know that you're not in a traditional medical setting anymore either. I say this because you are spending a lot of time with your patients. I always say as a psychologist, I get an hour with patients and I look at that as a luxury because I get to dive a lot deeper into the biopsychosocial of an individual and gather information to inform things. And in a multidisciplinary team, I can share that with my colleagues, where when they just talk to somebody for 10 to 15 minutes, it's hard to get that full clinical picture. So, I think as somebody who has a nice medical pedigree yourself, and then to come from academics and move into the way in which you're practicing medicine, this is quite unique. And I just want to highlight that to be able to inform the medical decision making that you're doing.
100%. We have a lot of informed consent, right? And I love academics. I love academics. I was a Duke trained GI doctor. Like, I love this stuff. I need more time with my patients. Right. All I do is clinic. I used to scope. I don't scope. All I do is hang out with patients and try to figure this frickin' thing out, right?
Yeah.
And I am committed to understanding this frickin' thing. So all I do is read about the complement system and bradykinin and intestinal permeability. Like, all I do is try to figure this out and try to find tools. But like, when we talk about like MCAS clinics, like, the hard thing about it is that these patients also have hypermobility and chronic pain,
right,
and POTS and dysautonomia. Are you telling me that they need to see an allergist, a POTS cardiologist, a PM&R doctor? Like, so what we try to do is we treat POTS. We treat dysautonomia. Like, I put people on IVIG for autoimmune gastroparesis where their stomach doesn't move, because it's all a package deal, right? And some people are lucky enough to have ME/CFS as well, where they have chronic fatigue and they crash after they do some things. And that's endothelial dysfunction. Like, there's layers to this, but like, it's so hard because it's kind of, it's one thing. But if you're in the traditional system, they're now seeing 3 doctors, each of whom are hard to get in with, right?
Hard to get into. Yeah, exactly.
I started treating POTS as a GI doctor. Alexis Cutchins has been like my mentor, who is like my cardiology tending in residency. And the local POTS doctor, I started seeing a ton of these patients. The local POTS one at UNC cardiologist started like training me as well, because like, he was booked out for years, right? And my patients were like, yeah, we got him pooping again and maybe less inflammatory, but they can't stand up with their heart going to 120 beats per minute. So it's like, well, how can we really satisfy the need here? It's like, well, let's try to do all the above.
Yeah.
And so that's also why we spend a lot of time with patients. And I branched out because, truthfully, I get 80 inbox messages a day, right? Like, there's no way to do this in traditional practice unless it's built a very specific way with a different whole billing system. It just needs time.
Yeah. So we'll see what happens. I think there's room for both. I mean, we need both models. That's the reality. We need both models. And we have a long way to go in the current medical systems. But thanks for sharing that. I just think it's an important kind of point to make and highlight.
This needs to be done in academics because I charge cash, right?
Yeah.
People can't afford it, right? And that's the only way. If you're not doing procedures, the only way you can pay the bills is if you spend this much time. And so academics, it needs to happen to serve a lot of these folks.
Yeah, you need a mix. I know in Boston, the mast cell docs were covering, everything had to be at least run through them. Like, they were the top dog provider for the patient, which I thought was really important. Like, they got the understanding that this is a systemic disorder. And so everything had to be like, whatever medication, whatever they were thinking, the different providers they were the top dog, which was kind of interesting to see. So I want to talk a little bit about hormones, estrogen, and their potential immune modulation. Do you think clinicians are connecting those dots dramatically as far as mast cell disorders and fluctuations? Because
what about testosterone? What are we even doing?
Oh, I'm just, we just wrapped up a Women's Health Month, so we're just talking estrogen. No, talk about hormones. I just mentioned estrogen, but I'm curious.
Yeah, testosterone women too, right? Like,
true.
There's IBS symptoms. Whether you attribute it to motility or pain sensitivity, really fluctuate with the cycle. And perimenopause is a uniquely challenging time for people with mast cell.
Amen.
Yes. That's a strong amen, Megan.
I know.
So if we're all bringing it back to mast cells, and not everything is mast cell activation syndrome, but so actually let's talk about motility first. So estrogen seems to kind of be the go button. Progesterone seems to be kind of rather the stop button. So constipation can get worse during the luteal phase when progesterone picks up. And then after the period, bowel habits can pick up again. But, from a visceral hypersensitivity, which I think is just mast cell driven nerve sensitivity via like TRPV1 and various other pathways. So estrogen seems to be rather inflammatory for mast cells and rather destabilizing, where progesterone is rather stabilizing. Testosterone is stabilizing as well. There have been people, young folks, or I think those are the case studies of folks who've transitioned from female to male, and their mast cell or their IBS gets a lot better once they transition around kind of super physiologic for their birth gender. For testosterone, their symptoms get a lot better. Yeah, so we see this a lot. And it offers an opportunity to potentially use hormone therapy to help with symptoms. It's not that, it'd be great if you just put everybody on hormone therapy and everybody gets better, but it's not that easy. It's still very much, it's a big decision to put someone on hormone therapy. It has to be the right thing for them. And, I usually bring it up in conversation if someone has a lot of catamenial kind of pattern to their symptoms, like, man, like everything's good until the luteal phase and everything is really, really challenging. We also think PMDD may be also a mast cell phenomenon as well.
Yeah. Well, that's why they're pushing the H1, H2 blockers on TikTok.
For PMDD.
Yeah.
Oh, okay.
Yeah. Oh, that went really, really, really viral.
Yes. We thought we found the answer.
For some, it may be really, really awesome for some, H1 and H2. Yeah, doesn't work for everybody. But yeah, so, sometimes just stabilizing hormones through the month is beneficial because the mast cells don't particularly like changes in those hormones when they're primed. And so sometimes just like the huge fluctuations during the month can be particularly challenging. And sometimes putting people on like a bioidentical progesterone can be a nice option, especially if they're dealing with a lot of insomnia and anxiety. But some people react poorly to it. So everything in this mast cell world is just truthfully so unpredictable. You just kind of try things. But, testosterone, postmenopausal women who have a lot of fatigue, decreased sexual drive, a lot of pain. Checking testosterone DHEA levels is something that we should probably start doing because as long as one knows how to do it responsibly, but it's another angle to take because we also as providers don't really get trained in hormone therapy as it pertains to like quality of life for women in perimenopause. So just another angle there. But yeah, so hormones have to play a big role.
And so you're seeing, I believe you kind of said this earlier, but do you feel mast cell activation is more common in women than men? Definitely.
Estrogen.
Yeah, estrogen.
I think my son has MCAS, but I think when he's 13, I think he has all these kind of, kind of behavioral symptoms where they're like, oh, it's just, he's going to grow out of it. And he's really itchy all the time and he's a little dermatographism. But I think when he hits puberty, I think if things are going to get a lot better. These mast cells, I think they just get primed by the environment, right? And some people like, why does barometric pressure really set people off? There's nothing inherent about barometric pressure. Mast cells can detect barometric pressure, but I think when they're particularly primed by the environment, that's when it flips it off. And I think estrogen is rather priming, but I think it's also much more nuanced than that. I think it's a gross oversimplification.
Yeah.
All right. So as we wrap up this really interesting, thought-provoking. We've been a little provocative. We've had these, we appreciate you getting on the hill and at least sharing your experience. Give us kind of a clinical idea to, if you'd like, one or two patients that you have seen. What's the scenario with MCAS and what does it look like in your clinic to work with them?
Yeah, so I'm trying to phenotype folks because the data is reliably unreliable in terms of trying to figure out what people will respond to. So I think there's a kind of, for lack of, I haven't like really thought about how I title this, but there's a intestinal permeability flavor of this where people have a lot of GI symptoms. They usually are more on the diarrhea side, but it's a little bit of both diarrhea and constipation. They bloat a lot. If you ask how they bloated, they're like, oh yeah. Everybody's had SIBO tests. Everybody tests positive. They treat the SIBO, it doesn't get any better. And we can talk about why I think that happens, but it's speculative. These are the chronic SIBO patients. They also have a lot of brain fog and a lot of fatigue. Food sensitivities, maybe some joint pains here and there, but it's mainly like brain, gut, some joint stuff, can't sleep very well. And that's one phenotype, painting with a humongously broad brush here. And I always have the same dialogue about the environment and diet, which, Kate, I need to talk to you about diet.
Yeah, we will.
To work for what people, because some, non-celiac gluten sensitivity, I think, is a mast cell phenomenon. Some people really do better on a gluten-free diet. Some people do better on a low histamine diet. Some people do better on a low FODMAP diet. And I've yet to figure out which of the three works for who. I think the more autoimmune phenotype works, or gluten-free works for the more autoimmune phenotype. That's kind of a different conversation. But in any event, so yeah, we'll talk about diet and we'd have a big conversation about stress and sleep and what are we doing for people dealing with chronic debilitating symptoms are invariably have a lot of stress.
Yeah.
If you're not doing this already, we should probably make a plan for it. Like, is it CBT? Is it GI psychology and working with someone like Megan? Is it, there's brain retraining things like DNRS and primal trust that people have really benefited from. I haven't done that myself, but I've heard of these. There's various different things. Is it taking a walk outside? Is it meditating? It's always getting good sleep. So these are things that we talk about. And then we talk about, different pharmacotherapies as well. And that's kind of a bigger conversation. And I hesitate to be like, just use this, because it's certainly not a one size fit all approach.
When you described that first phenotype, I like to normalize for people that wouldn't be shocked if you were depressed. I wouldn't be shocked if you've been navigating all of this on your own, or you've seen God only knows how many specialists about this. It would be shocking if you weren't depressed, or and maybe, of varying degrees, right? It might be mild depression when you're doing pretty well. It might be no depression if you're doing okay, more severe depression when all of this is storming. So yes, like stress, but I couldn't envision somebody not benefiting from a consult with a psychologist to just normalize that this is a lot, and it's not going to get better overnight either.
No.
But it can get better. It can get better.
Great point. Everybody should have that in their corner. I'll also say that there's something about chronic inflammation that really tips people towards fight or flight. I always ask people, what happens if I keep you and dropped a pan behind you? Everybody's going to jump through the roof. Not everybody. A lot of people are on edge. This physiological, and it's like this. Some people have kind of intrusive thoughts and worry, but a lot of people are just this physical anxiety that's so incredibly unique. So I try to support people from the immune side, the nervous system side, whether that's like POTS or calming down that nervous. There's like guanfacine is a really nice option. But again, I don't want to paint with a broad brush, but also like addressing their pain and their nausea. And so it's like, because you don't want to do a million things simultaneously because it gets overwhelming. And a lot of people with MCAS don't respond well to medications. You're like, they're the people that doctors like, no one's ever responded this way to a medication. Like this couldn't have happened. That's part and parcel of having MCAS, unfortunately. So it's starting low, going slow, understanding the process, and a lot of communication. Like I talk to patients a lot, because that's the only way to kind of make sure they're on the right path. And if I misread the situation, I get things wrong, right? And then we say, I'm so sorry. And then we let's refocus and then kind of maybe take a different angle here.
It totally humanizes the experience of having a chronic illness or of just medicine, that we have to find providers that we trust. We have to use the science that's available. We have to instill hope for people, and also the realistic expectations of the journey here. It's going to be a journey. And I think it goes a really long way for patients when they have a provider that can be really true and honest about all of that. And also that, hey, I'm going to be here. We may make mistakes. We might not be where we want to be yet, but we're working through this. That's, I think, maybe the special sauce of this.
Well, I think too, like the whole notion of having, and I do this in my practice, like this is plan A, but I have plan B, C, D, and E, maybe F, G, and it's like, so they know that, okay, if I don't get better after A, like no worries, we've got more in the toolkit. That leaves them with that hope.
Exactly.
And one other point I wanted to make, and, this patient population, stress is always on the top because they've gone through so much and it is stressful, to both of your points. I see a lot of people with IBS, but in MCAS, it's like the top of the list is really trying to figure out ways to mitigate their stressors, because living in fight and flight all the time, it might be just saying no, all of the things. But even though I'm a dietitian, it's on the top of my list with these patients because it does help them. I see it repeatedly.
You have to address it because it's hard to make a lot of progress if that isn't shored up first.
Yeah.
Talking about, and none of these patients sleep well. None of them do. They always wake up at 2 a.m. in a panic. It's also like a secret mast cell question. Do you wake up at 2 a.m. in a panic? And there's something weird about, cortisol is anti-inflammatory, right? And cortisol is lowest at like 2 a.m. And I wonder if like that nadir of cortisol is when people like their mast cells are the angriest, but I'm making that.
Interesting.
Fascinating.
You're going to be one of these. You're going to go down as one of those gurus that like, I remember when H. pylori was like, it's a bacteria. It's not stress that you're getting ulcers or all these other things they thought ulcers were caused by, And now it's going to be this mast cell activation thing that you're living through probably a little bit like, what is he saying? He's using what for what, but It changes medicine because we have to go outside of the box when the answers aren't there sometimes.
And I think I see the patients who have seen 11 doctors, right? And so it's like, well, what other answers do you have, right? This isn't first line, right? I'm not, you have to do your due diligence and make sure that nothing else is going on. But I think that's also the counter argument. It's like, well, what else do you got?
Right.
Right.
More neuromodulation and more, like, it's just, sometimes the DBGI, it's like, well, let's just do more neuromodulation. It's like, at some point in time, you can't do more neuromodulation. There has to be another hand to play here. And it, of course, worked for so many people. I don't want to minimize that, but there's also, that's like me, the defensive side of me being like, well, that's why we try X, Y, Z, but it doesn't always work. But yeah, so the other phenotype of patients is the more classic allergic type folks who have more non-allergic rhinitis, a lot of hives, a lot of vasomotor symptoms, like tons of flushing, tons of seasonal allergies. But they also have, like, they're not the classic allergy patient because they also get the brain fog, they get the fatigue, they have some joint pains, they're hypermobile as well. So that's the more like allergic type phenomenon. I think most people in GI clinic will see the former patient, but this patient fits more of the kind of the allergy type. And that's probably the second biggest subtype that I see. And that's more, obviously you have to, all the things that we spoke about are very important, like diet, lifestyle, stress, sleep, but then there's just like a different toolbox that you theoretically use there.
Well, we'll look forward to the paper, those phenotypes, the write-ups. You got to get the stuff out there to provoke the conversations. I'm sure there are some medical situations you walk into and you're like, all right, I'm ready. Let's go. Let's talk. Like, you're okay.
I will have patients whose family are all physicians.
Yeah.
I'm like, okay.
Here we go.
Let's talk about what I think is going on here. And but I'm also not defensive. I don't get angry about this stuff. Like, I'm not gonna, if you think I'm doing a bad job, I want to hear about it. I want to know about it so we can talk about it. I think you could critique me for like over pathologizing when things just may be anxiety. Like, I get all that critique if you want to, but I'm just open for dialogue and thinking that maybe there's some stuff out there that we don't quite get yet. And that's where I'm trying to live without overstepping and being too aggressive, too and irresponsible. So it's always informed and consent, always start low and go slow. I don't want anybody to think that I'm just like going rogue and doing crazy, crazy stuff without, in my hope, the patient understanding exactly what the intent is here. And we're watching things so incredibly closely to make sure that we're moving in the right direction.
I think that's a great wrap to this, I think, just beginning of questions that we might ask you. And we may have to bring you back again next year to see where we've moved the needle. But before we wrap up, we like to do a speed round. So we get to do that with you. And I'm going to ask the first question here. What's one word your friends would use to describe you?
I think goofy. Goofball.
Okay.
I have to be very serious about a lot of things. Like, I'm obviously serious about my job and this stuff, but I try to keep things pretty light, even when they're pretty tough.
I'd say that's pretty evident from your Instagram accounts. We'll actually make sure we link that as well. So coming from the dietitian, I'd like to know what one food is always in your fridge.
I don't know if this counts, but iced coffee.
Iced coffee.
I abuse iced coffee.
We won't hold it against you.
Yeah, don't look at my bowel, have my stool, my Bristol stool chart.
I was going to say, uh-oh.
I go on podcasts and they're like, Zach, what do you eat on a day-to-day basis? I was like, don't ask me. This isn't why you invited me on here.
All right. Nutrition consult is next.
That's right. That's right. Okay. So this may tell us even more about you. Guilty pleasure TV show or movie?
Oh, man. So I have young kids, and so I kind of end up watching what they watch a lot. There's a show, Is It Cake?
Oh, yeah.
These are the most talented people I've ever seen.
I'm not familiar with this. Is this a kids program?
It's not, but kids love it.
Awesome. Okay. So Kate, they will take a whole room, a living room, a set, and they say, pick what's real and what's cake. And random objects, the couch will be cake. And you don't even know. And then they cut into it. And it's like,
oh, yeah. What?
Saying it out loud, it sounds pretty silly, but holy cow, it's the best.
Yeah. Okay. I'm checking that out soon. All right. So what is an instant mood booster for you? Iced coffee.
I think playing basketball is I love playing basketball.
Yeah. I like playing basketball too.
All right. Your UNC roots there. That probably.
Yeah. I went to Duke and UNC, so I'm a little bit, but I'm a UNC.
Yeah. You're pulled. Yeah. Okay.
Yes.
And then cook at home or eat out?
Man, I like to eat out. I get really excited about eating out. My kids don't eat any of my cooking. So I think when I eat at home, I'm associating with just complaining about the meals that my wife and I put on the table. So eating out at least shifts the pressure away from us.
Are you like my family? We're the first ones for dinner, 4 p.m., 5 p.m. eating out, and then it's obviously different on date night. But, we are like early bird specials as family going out. Yeah.
My dinner is, I start getting hungry around 4:45 now. So great.
Nice.
It's just the whole restaurant's for you.
That's right. It is a private dining experience. Yes.
Perfect.
Yes.
Perfect.
Yeah. Plus, no one wants to be around my kids when we're eating. It's just
too crazy. They're a little goofy like you.
Very goofy.
Well, this is amazing. We appreciate your time. We know that you have very graciously talked about our podcast before. And so to have you on, we had a lot of fun today, and we're really appreciative of the work that you're doing. So thanks for joining us.
Of course. I'm such a big fan of you guys. So thanks for all you do.
No, thank you. So please like and subscribe and share the Gut Health Podcast.
Thank you for joining us as we grow this gut health community. We hope you enjoyed this episode, and don't forget to subscribe, rate, and leave us a comment. You can also follow us on social media at the Gut Health Podcast, where we'd love for you to share your thoughts, questions, and experiences. Thanks for tuning in, friends. Thank you for joining us as we grow this gut health community. We hope you enjoyed this episode, and don't forget to subscribe, rate, and leave us a comment. You can follow us on social media at the Gut Health Podcast, where we'd love for you to share your thoughts, questions, and experiences. Thanks for tuning in, friends.